So I have to introduce Giovanni Mosti. I think he's the next speaker. Everybody knows him because he is the master of compression, I would say. So he is speaking about compression and leg ulcers and diabetes, which is always an issue because in old guidelines, diabetes used to be a contraindication for compression treatment. However, that might have changed, and I'm looking forward to your presentation, Giovanni.
Dear Erhardt, thank you so much for your very kind introduction. It is a pleasure for me to be here, and of course I would like to thank also Attilio for his kind invitation and Mehdi for the organization of this beautiful meeting, even if virtual. So it is very difficult for me, as I told you yesterday evening, to work with this software, but I will try to share my screen. Maybe I was able to do this. It's okay? Are you able to see?
It's totally fine. Thank you very much.
Okay, perfect. So I do not have any conflict of interest for this presentation, and I want to start from here. I'm not speaking about diabetic foot. You see not a nice, but a picture on the left side of the screen. I'm speaking about venous or mixed ulceration in patients with diabetes mellitus. And you certainly know that compression therapy is a very debated topic and is actually, as Erhardt said, a contraindication and an exclusion criteria in a lot of studies on compression. So we don't have data at all, but we have just a single study on ulcers in patients with diabetes mellitus, and you see here that it is a very old study. And then we have studies on diabetes or arterial patients, but regarding edema and not ulcers. And I'm very happy to have seen the last study by Dr. Roeder speaking about compression in diabetes, and particularly concerning microcirculation. So the fear of compression therapy in diabetic patients is very clear. We are afraid to compromise the arterial system, and we are also afraid to produce skin damages in patients who cannot be aware of this damage, of this symptom, of pain symptom because of the neuropathy. But today we have an increasingly high incidence of diabetes and we have a high prevalence of diabetes in patients with chronic venous disease and eventually venous leg ulcers. And so what to do in this case, in these patients with venous or mixed leg ulcer and diabetes, because in venous or mixed leg ulcer, compression would be recommended. My background, I always used compression in diabetic patients without major problems, I would say. And in recent years, we also performed a study involving 180 outpatients with venous leg ulcer and mixed leg ulcers, and many of them had a coexistent diabetes. So this new work that was recently published, it is a sub-analysis of this previous work, and we wanted to investigate if compression can be safely applied in diabetic patients with venous leg ulcers and mixed leg ulcers, and if compression can hindrance or delay ulcer healing. You see here the case series. We had 180 patients, 109 with venous leg ulcer and 71 with mixed ulceration. And you see that in this group of venous leg ulcer, we had 69 non-diabetic and 40 diabetic patients. And in mixed ulceration, we had 38 non-diabetic and 33 diabetic. we had some patient lost at follow-up, and so you see the numbers of the patient who were able to conclude the study. I want to show you that the only statistical significant difference in this patient, of course, is the ABPI that was greater than 1 in patient with venous leg ulcer and lower than 1 in patient with mixed leg ulceration. And you see here that at an average, it was 0.8 in non-diabetic patient and 0.65 in diabetic patient, and there is no difference in this respect between diabetic and non-diabetic. The other main variables, median leg ulcer surface and median leg ulcer duration, is about the same. You see 8 months as a median ulcer duration and about 40 square centimeter for ulcer surface. From a treatment point of view, the routine pharmacological treatment remained unchanged. The local treatment was the same for all the patient, foam dressing for all the patient, and Cadexomer powder in infected patient, in infected ulcers, sclerotherapy of the vein with the reflux directed to the ulcer area, compression therapy by multi-layer, multi-component bandages exerting in supine position more than 60 millimeter of mercury in venous leg ulcer and not higher than 40 millimeter of mercury in mixed leg ulceration. Arterial procedures were postponed when the treatment was ineffective or the ulcer was worsening. I don't want to say too much on this. All of you know very well vein ultrasound guided from sclerotherapy. It was performed by sodium tetradecyl sulfate, 3% in the trunk and 1% in the tributaries, and the sclerosant foam was prepared according to the Tessari method with a ratio between liquid and gas 1:4. Outcomes, you see the compression pressure here, and you see that as usual we had a significant compression pressure drop between application and removal of the bandage, and you see also the difference in compression pressure at application, about 65 in patient with venous leg ulcer, dropping to 33 at bandage removal, and about 40 in patient with mixed leg ulceration, dropping to 25 at bandage removal. There is no difference in exerted pressure between diabetic and non-diabetic patients. So we exerted the pressure just according to the presence of arterial disease, independently on the presence of diabetes. Ultrasound guided foam sclerotherapy was performed in 50 patients with non-diabetic and 28 patients diabetic in blue in the venous leg ulcer group, and in the mixed leg ulceration, 32 were not diabetic and 18 were diabetic. And you see the dosage and the number of sessions that were necessary to have the complete occlusion of the venous segment. And here are the results. You see that in venous leg ulcer, there is a delay in patient with diabetic compared to not diabetic. And in this case, so in the case of venous leg ulcer, the difference was statistically significant, even if in terms of week, you see that there is no a huge delay, just 3 weeks of difference, but this difference was statistically significant. And in a patient with mixed leg ulceration, there is also a delay in diabetic patient, 2 weeks, but the difference in this case was not significant. And you see also the survival curves here showing what is clearly reported in this part of the slide. Then we calculated also a multivariate analysis, taking in consideration sex, age, smoking habit, arterial hypertension, BMI, and ulcer surface. And if you correct all these variables, you see that, again, the diabetic patients had a delayed healing compared to not diabetic, and that again it is statistically significant, this difference in patient with venous leg ulceration. It is not significant in patient with arterial disease. Coming to symptoms are also related. Obviously, in patient with mixed leg ulcers, the pain was higher than in patient with pure venous leg ulcers, but you see that the pain was decreasing over time. The only difference between mixed and venous leg ulcer is that the mixed leg ulcer, the decrease is lower, but at the end of the treatment, the pain was significantly reduced in both groups, and also in this case, independently from the presence of diabetes, from the coexistence of diabetes. So once again, it was mainly the arterial disease or the venous disease, the main characteristic of regarding pain reduction. Symptoms compression related, also this is very important because you know that compression is thought to be painful. This is not the case when the compression is properly applied. And you see that in this group there is some tightness sensation at the bandage application in patient with venous leg ulceration, because you remember that the pressure in this patient was higher than 60 millimeter of mercury, but this tightness sensation was decreasing over time and coming close to zero at removal time because of the pressure reduction. And again, there is no difference between diabetic and not diabetic patients regarding compression. So it is still necessary, so to say, to be so afraid of compression in diabetic patient. I would say no, and I would like to explain why I'm convinced that we shouldn't be so afraid about compression in diabetic patient, because you see here that diabetic wounds show decreased vascularity and capillary density, and wound closure is frequently delayed in patients with diabetes, but adequate compression showed to increase rather than decrease arterial perfusion. So this is a very important point, and compression is certainly very effective in preventing or reducing edema. And if you prevent or reduce edema, you also reduce the distance between nutritional capillaries and tissue cell, even with a low pressure. I'm very happy that Erhardt reminded everybody that a low pressure is enough to reduce edema. And angiogenesis impairment in diabetic wounds was associated with a low level or down regulation of the VAGF, but you know that adequate compression showed to upregulate VAGF, thereby contributing to improve neovascularization that is connected with ulcer healing. Ulcer in diabetic patients show a derangement of inflammatory mediators, and I'm very grateful for Erhardt once again, because he spoke so effectively and so nicely about inflammation. And you know that inflammation, as Erhardt already told us, was proved to be effective in downregulate pro-inflammatory mediators and upregulate anti-inflammatory mediators by the group of Beidler and co-workers. So in conclusion, venous leg ulcer and mixed leg ulceration in diabetic patient heal with a slight delay compared to similar ulcer in non-diabetic patients when treated by local dressing, ultrasound-guided foam sclerotherapy of the vein with the reflux directed to the ulcer area, and compression therapy. And compression, when properly applied in this condition, does not represent a safety issue and does not enhance the ulcer healing. We have unfortunately no data, and this is a kind of request for MEDI. We have no data on clinical effectiveness on venous leg ulcer and mixed leg ulcer in diabetic patient in non-education dependent, so to say, compression modalities, because you certainly know that bandages need a very effective education to be properly applied, but stockings or adjustable compression wraps are more independent from education, so it would be extremely important to have data on this material, because as Hugo always reminds us, we are kind of dinosaurs using bandages, and certainly for the new generations, an easier compression modality would be very important. I would like to thank you all with this spectacular view from our beach during the summer. Thank you so much for your attention. I don't hear Erhardt.
Try to open, yes. We did it both. Thank you very much for your perfect talk and the nice data also from your own study showing that this is an interesting group for compression. And we will have the next talk, I think, on a similar topic. Mrs. Erhardt from Germany will speak about safety of the compression stockings in patients with diabetes or peripheral arterial disease. Please.
Yes, thank you very much for the nice introduction, Professor Rabe, and a warm welcome also to all of you in the virtual room. I hope you can see my presentation. Maybe you can give me a short hint.
I can see it. Perfect.
Okay, thank you very much. So it's my pleasure to present you the data of a currently published study with a new round-knitted product, namely with the Medivin Angio. And in this study, we demonstrated the safety of this specific medical compression stocking in patients with diabetes mellitus or peripheral arterial disease. And so I think this presentation perfectly fits to the data already presented by Dr. Mosti currently. And you all know that compression and movement is the basic therapy of chronic venous disorders. But what happens if the patient has, on the one hand, an indication for a medical compression stocking, but on the other hand, he suffers from a comorbidity like, for example, diabetes mellitus or PAD, or maybe patients who suffer from a chronic venous disease plus a diabetes mellitus and PAD. And I think this is like a kind of changing from the green traffic light, so that means go on with compression therapy, start with compression therapy, to more an orange traffic light. So it's like patients at risk. So it's like the orange traffic light. Should I go on with compression stockings? Should I apply medical compression stockings? And we already heard today why there is this uncertainty regarding the application of medical compression stockings in these patients at risk. And you are all familiar with the well-known risks and contraindications for medical compression stockings and medical compression therapy in general. We all know that severe PNP, especially in patients with diabetic mellitus, is a risk regarding compression therapy, of course, due to the sensory loss, to the reduced sensation of pain and pressure, and then maybe compression might have even detrimental effects in these patients with diabetes mellitus and diabetic neuropathy. On the other hand, we have absolute contraindications, and we all know that severe PAD is an absolute contraindication. And although now we have this great definition, what is really a severe PAD, and also the definition was done by several key opinion leaders also present here in the virtual room. And although we know these parameters quite good, there is still this uncertainty in patients with mild to moderate PAD. So in my opinion, we have these two risk groups of patients, namely the patients with severe PNP and diabetes mellitus patients, and also we have the patients with mild to moderate PAD. And therefore, unfortunately, we have still this gap in patient care, also due to the lack of scientific data for these patients suffering from a chronic venous disorder on the one hand, but co-suffering from a diabetes mellitus and diabetic PNP, and also in patients with chronic venous disorders and mild to moderate PAD. And therefore, of course, we need a solution, and I think we need an overall approach, a global approach, and therefore we designed a specific product, namely the Medivin Angio, and this specific product has unique product features which perfectly fit to the patient needs. So for the patient needs in patients with PAD and diabetes mellitus. But of course, on the other hand, we also need scientific evidence. And therefore, we have proven this specific stocking Medivin Angio in a clinical trial. And I'm happy to present you now the results of this publication and of this study, because it was currently published in the BMJ Open Diabetes Research and Care Journal. So let's start with this clinical trial, and let's start with the included patient population and with the most important inclusion criteria. So we nearly included 100 study participants, and we also included a control group with healthy subjects, because we were interested what happened under compression in this healthy subjects in comparison to patients with a chronic venous disorder, so with a venous leg edema plus PAD. And when you have a look at the most important inclusion criteria, we included patients with a mild to moderate PAD, so up to the Rutherford category 3 and up to the Fontaine stadium 2. We included the patients with an ABPI of less than 0.9 and more than 0.6. And we had the third group, namely the patients with leg edema due to the chronic venous disorder and diabetes mellitus. So we included really these two relevant comorbidities, which are really prevalent in patients with chronic venous disorders, and compared them with the healthy control group. Since I already mentioned, and since you all are familiar with, the safety issue are the most important issue in these patients at risk, so in the patients with PAD and diabetes mellitus. And therefore, of course, we decided to have safety as the primary endpoint in the study. And at first, we documented the MCS-related adverse events in these patients. So we documented any skin lesions like constrictions, abrasions, or pressure points and pressure peaks. And in my opinion, more interestingly, was even the second part of the primary endpoint, namely, we directly measured the changes in microcirculation. And therefore, we used the so-called O2C method, the oxygen to C method. That means we really measured the post-capillary microcirculation. So the microcirculation in the so-called leafy corner or last meadow. And there we measured the oxygen saturation and the relative blood flow. And on the other hand, we were, of course, also interested in the patient's subjective feeling regarding this new stocking. So these are more the objective parameters analyzed by the physician. And this secondary endpoint was more a patient-related outcome. So the patients could rate the wearing comfort on a Likert scale from 1, optimal wearing comfort, to 10, massive impairment. How was the visiting scheme? At first, we had a baseline measurement without a medical compression stocking, and we measured the microcirculation without compression as a baseline measurement. Then we applied the Medivin Angio in the compression class 1 for 3 hours. And then for additional 3 hours, we applied the Medivin Angio in compression class 2 on the same leg in the same patient. So this study design enabled us really to analyze both compression classes in one and the same patient, and really to analyze both compression classes 1 and 2 in a time frame of about 6 hours, which was the total observational time. And I think in this time frame, it's really relevant to see, are there any changes in microcirculation. I also want to present you the measuring points of the O2C probe. We had 3 measuring points. At first, we had the measuring point at the big toe. And I think you can imagine why we used this measuring site, because there, that's the big toe is the most peripheral, the most distal area of the lower extremity. And so this big toe, of course, is the most critical site in patients with PAD and diabetes mellitus. We had a second localization of the O2C probe at the lateral ankle joint. And of course, you can think why we choose this site, because you know that the medical compression stocking has the highest compression pressure at the ankle. And so this might also be a critical site regarding maybe an impairment of microcirculation. And last but not least, we had also a third measuring point of the O2C probe at the calf. So a more proximal area and a more area in the direction of the calf muscle pump. How was the positioning of the patient? We decided to have 4 measuring positions of the patient itself. So we had the patient in the supine position, in the sitting position, but also in the standing position, because you know when the person is standing, then you have an hydrostatic pressure of about 100 millimeter mercury on top on the lower extremity. And we did even a so-called provocation test. That means we elevated the leg up to 65 centimeter. So we have a 50 millimeter mercury increase in the perfusion pressure. So what were the results of the study? And I already mentioned that safety was our primary endpoint. And we documented the MCS-related adverse events. And good news, there were really no adverse events during the whole course of the study. We could detect no skin lesions, no constrictions, and no abrasion or pressure points in these patients. And also we did not detect, or we had no study discontinuation, a premature study discontinuation in any patient. More interesting, I think, are the results regarding the changes in microcirculation, because these are really direct parameters of the microcirculation. And here I present you the results of the oxygen saturation measured by the O2C method. And remember, the O2C method is measuring the post-capillary microcirculation. So a threshold or a critical value of oxygen saturation by this method is 10%. So when the oxygen saturation is below 10%, then the tissue is really in danger of hypoxia. And when the value is more than 10%, then the tissue is not in acute danger of hypoxia. And here I present you the results for the diabetic patients in the sitting position. And in this left graph, you can see the sitting position at the big toe, so the most peripheral area. And here on the right side, you see the patient in the sitting position with the measuring probe localized at the ankle, so at the site with the highest compression pressure. You can always see 3 box plots. The most left box plot represents the baseline measurement without compression. Then you see the box plots with compression class 1 and then compression class 2. And as you can see here in the sitting position, there is a stable microcirculation even upon application of compression class 1 and 2. And this is true for the position at the big toe and also at the ankle. So there's a stable microcirculation in comparison to the baseline measurement without compression. Interestingly, at the ankle, so at the ankle where the highest compression pressure is apparent in the stocking, you can even see a significantly increase in the oxygen saturation. What happens in the standing position? So again, diabetes mellitus patient in the standing position at the big toe and at the lateral ankle. And again, you can see that the baseline values and also upon application of compression class 1 and 2, that there is a stable microcirculation at the big toe, and the values are quite high and quite above this critical threshold of 10% oxygen saturation. And the same is true also in the standing position at the lateral ankle. And again, you can see here no aggravation and worsening of the microcirculation, also in the standing position, where we have the hydrostatic of 100 millimeter mercury on top. So these were the results for the diabetic patients. But what's about the patients with PAD who have really suffered from a micro and macroangiopathy? Again, you can see the PAD patients in the sitting position at the big toe on the left side, and in the sitting position and at the ankle on the right side. And again, you can see in the sitting position at the big toe that the microcirculation is absolutely stable and that there is no reduction and no worsening of the oxygen saturation upon application of both compression class 1 and 2. And again, in the sitting position at the ankle, you can even see an increase in the oxygen saturation at the ankle. So also in patients with PAD, in the sitting position, no changes in microcirculation. The stable microcirculation is absolutely apparent, and the values are always highly above this critical value of 10%. What happens in patients with PAD in the standing position? And although here you can see a slight decrease in the oxygen saturation, there is nevertheless a stable microcirculation in the compression class 2 and upon application compression class 1 and 2. So stable microcirculation also at the big toe, so at the most peripheral area, also in PAD patients in the standing position. And again, at the ankle in the standing position, you can even see an increase in the oxygen saturation at the ankle, so where the highest compression pressure is apparent. On the next slide, I summarize the results of the O2C method and the changes in microcirculation. And I also want to show you, of course, the results of the elevation of the provocation test. And here I can tell you that the changes in the microcirculation upon elevation were absolutely similar to the changes in the healthy controls we included in the study, because there was also a worsening, and this was also true in the PAD and diabetic patients for some positions. But I think we have to focus on the physiological positions, because these are really the physiological positions of the patients in their daily life, namely in the sitting and standing position. And here we have an absolute stable microcirculation, which was also comparable to the healthy controls. And as I already mentioned, at the ankle, we even see this improvement of oxygen saturation and also of the blood flow. And I think that is really also very important in the context of applying compression therapy in these patients, because I think that this anti-edematous effect is also a medical necessity, also in these patients with PAD and diabetes mellitus. Because when we have an edema, then also ischemia can increase, and it was already mentioned by Dr. Mosti in the current presentation, because this is due to this extended diffusion distance from the capillary to the cell, which then results in an increased tissue hypoxia. And on the other hand, an impaired arterial perfusion might further increase edema due to the hypoxic capillary damage. And in order to get out of this vicious circle, we need really compression therapy, and we need a successful therapeutic reduction of the edema, because this is important not only from a microcirculatory and symptomatic point of view, but also from a prognostic point of view. And therefore, we can really hypothesize that also in our study that the high pressure at the ankle was responsible for emptying the veins and therefore lowering the venous hypertension in the veins, and therefore increasing the arterial venous pressure gradient by increasing the arterial inflow and finally improving the blood circulation and the microperfusion. And I mentioned to you that we were also interested not only in the objective parameters, but also as a secondary endpoint in the subjective feeling of the patients. And therefore, they could rate the wearing comfort of this new and unique stocking. And as I told you, they could rate the wearing comfort on a Likert scale from 1 with high wearing comfort and optimal wearing comfort to 10 massive impairment. And you can see that for both compression classes, we had really this high wearing comfort between 1 and 2. So also the patients are very satisfied with this new stocking. So to sum up the data regarding the study, to my knowledge, that's the first study that really evaluated the safety of medical compression stockings in parallel, namely in parallel in two relevant and potential comorbidities, namely in PAD and diabetes mellitus, and also including a control group with healthy subjects as a reference group. And I demonstrated to you that for these patients at risk, the use of the medical compression stocking medium in angio was safe and feasible, and this was true for both compression classes. And this is very important since we really did this intra-individual analysis and study design. And of course, the microcirculation, as I presented to you, is very, very important. And this microcirculation was stable under both compression classes and was comparable to the healthy controls. So what are the specific features of this new medium in angio, this specific round-knitted medical compression stocking? We designed the stocking in order to have specific product features that perfectly meet the patient's need regarding micro and macroangiopathy, and in patients with diabetes mellitus, of course, also due to neuropathy. And so we designed the stocking from the proximal to the distal ending, and we equipped this stocking with specific product features. And so let's start with the proximal ending. So at the proximal ending, we have this broad trigger border in order to ensure a flat and equal pressure distribution, and in order, of course, to prevent a further impairment of the arterial status, maybe due to constrictions. Then let's go more distal. This stocking has a ribbed structure at the calf, and you can imagine why we designed the stocking with this ribbed and strong structure, because of course we want to ensure a high working pressure and a low resting pressure. And also due to this ribbed structure, we can ensure a good positioning of the stocking on the lower extremity of these patients. And then the most important feature, I think, is the merino plush within the whole foot area. So we have this optimal padding. I depicted here a picture of the inside of the stocking. And we have this optimal padding in this whole foot area up to the lateral and to the medial angle. And of course, this is absolutely necessary in patients with PAD and diabetes mellitus in order to ensure this optimal padding, especially of the bony prominences, like, for example, the ankles, but also the toes and the toe joints, and also especially in patients with diabetes mellitus on the plantar side of the foot. Moreover, we have 2 foot lengths. That means we offer also in the ready-to-wear products 2 foot lengths in order to ensure this optimal fit, because you know the peripheral area in patients with PAD and PNP is the most critical area. And so we, of course, have to ensure this optimal fit and to prevent any constrictions, any wrinkle formations, or any tension on the toes. Within the foot area, we have a low compression pressure, but we have compression because, of course, we need this optimally balanced pressure on the one hand for the venous system in order to reduce the edema. But on the other hand, we also need maybe a reduced compression pressure to the arterial status or to the PNP in patients with diabetic neuropathy. And last but not least, we have this extra long and flat tip seam. This tip seam is 2 centimeters longer than in a normal compression stocking. And therefore, we have not only a reduced tension on the tip of the toes, but also at the lateral and also at the medial and lateral big and small toe. And finally, I want to close up my presentation with this great publication, which was currently published by key opinion leaders, which are also present here in the virtual room, because I think the new stocking, the new and currently presented study, and also this great international consensus document now gives us the opportunity also to offer stockings to patients with PAD and diabetes mellitus, because also in this nice consensus document, there are several recommendations which perfectly fit to my presentation, because also there is mentioned in the recommendation 1 that patients should really be screened for risks of complications like PAD, microangiopathy, or diabetes. And there are also mentioned these specific features which are relevant, especially for patients with diabetic neuropathy, namely the padding of the bony prominent structures. And so remember the padding of the neo-median angio in the whole foot area. They also mentioned the special care of fit. So maybe remember the 2 foot lengths which we are offering. And also the low pressure is mentioned as one aspect which is relevant in compression therapy. And therefore, I think on the one hand, the ribbed structure is really a good feature in this median angio, because now you have a high working pressure and a low resting pressure, and you also have this low compression pressure in the foot area. And thank you very much also to all the key opinion leaders here present in the virtual room to really define, because I think now we have really the opportunity to discriminate between severe PAD and mild to moderate PAD, and really to bring compression to these patients with mild to moderate PAD and diabetes mellitus. So I think we can now spread this information worldwide and have the opportunity with a new product and with scientific evidence. And with these remarks, I want to close my presentation, and I want to say thank you very much for your attention, and I'm looking forward to your questions in the discussion session. Thank you very much.
Thank you very much. This was a very nice presentation. We will discuss everything at the end of the session, I think. So I hand over to Attilio, no, not to Giovanni, to announce Attilio. Or shall I do this?
Thank you very much.
It is really a pleasure for me to introduce my great friend Attilio, who has a very difficult presentation today because he's speaking about bioimpedance assessment of compression in lymphedema, but I'm sure that he will make very clear his presentation, and we will be very happy to understand more on bioimpedance. Attilio, please.
Thank you very much. Can you see my desktop?
Yes.
Yes,
Okay.
we can see it.
Okay. So I slightly changed the title, just talking about lower limb edema and not just lymphedema, let's say. So this is my disclosure slide, but these companies had no interference on my, let's say, on my presentation. So long time ago, 22 years ago, we started to think about edema as an issue of fluid, but also, so we mean venous and lymphatic problems, but also it was an issue since the very beginning of tissue, interstices. So bioimpedance was started long time ago for many other reasons, but about in 95 and then in 2001, the Australian colleagues started to speak about the use of bioimpedance, especially in lymphology, in lymphedema, and the very first articles clearly highlighted the possibility of this new technology. With Dr. Shingale and Dr. Elio had the luck to publish this article trying to evaluate a few devices to investigate limb volume measurement, and somehow we spoke about bioimpedance, though we know that other methods are considered somehow the most validated ones, such as water volumetry, for example, or simple volumetry derived from circumference measurement. We have an issue. The issue with this method is that when we measure volume, we may measure, for example, fat changes, we may measure muscle changes, and not just fluid changes. That's why we probably need, let's say, a more validated and more sensitive method to assess the changes of fluids, especially fluids, and not just the volume of the limb. And this could be the option for bioimpedance. Furthermore, when we speak about tissue assessment, things are more complicated because we know that we have ultrasound, tonometer, biopsy, but again, a more sensitive method could be possible. And here, bioimpedance comes. What is bioimpedance? Well, everybody knows about bioimpedance in the body, let's say, for, let's say, nephropathic patients, for example, or for nutrition reasons. But with the low intensity alternating electrical current, we may investigate the tissues because they are a kind of conductors and semiconductors which, when they are pass through the electricity, they respond, and we can investigate at the end of the day the extracellular fluids, the intracellular fluids. And the basic principle of bioimpedance is that the impedance is inversely proportional to the amount of the extracellular fluid, including lymph. So the higher the impedance, the higher the consistence of the tissue. The lower the impedance, the higher the fluid amount. Beyond the classical extra and intracellular water content and the classical lean and fat mass evaluation, we know that bioimpedance, or better with bioimpedance spectroscopy, we can investigate the extracellular resistance, which is one of the two components of impedance. And the resistance relates to the extracellular fluids, so with edema. Reactance, on the contrary, deals with the, let's say, membranes of the cells, but even more recently, we know that cellular membrane capacitance is the parameter that we may get by bioimpedance to assess the cellular membranes. This is one of the possible devices you can use, this one from the U400 LDEX we use from the Australian company. It has been validated through a series of very good level articles. And the very beginning of this technology focused on the possibility to, let's say, investigate the lymphedema index, the LDEX, which means that you can divide one impedance of the affected limb, for example, over the unaffected limb. So through this index, you may understand if there is any difference between the two limbs in terms of impedance. When we started to apply this technology, we found some little problems, because when you have a bilateral edema, this index is not applicable. And that's the same when you have fibrosis, for example. So at the end of the day, we decided to go through the raw data analysis. And the raw data analysis, when you perform a bioimpedance examination, permits you to know a little bit more about resistance. So we told before that the higher the fluid content, the lower the resistance, and vice versa. And also reactance, which means that the higher the reactance, the healthier the tissue. So through raw data, you can understand also cell membrane capacitance, which is the third interesting parameter you can get through bioimpedance. And it has been used, for example, in cancer and in other chronic degenerative disease. So these parameters can be very easily investigated through these devices, and then you can understand how much is the resistance in the limb or in the, let's say, segment of the limb. And then you can detect the cell membrane capacitance, which relates to the tissue. So you can investigate the tissue. And then you can also, of course, detect reactance, which is another way to detect the tissue composition. What we did in the last 6-7 years was to investigate a segment of the lower limb. For example, the lower leg, because we know that there may be differences when we have lymphedema or whatever edema between the distal part of the limb and the thigh. So to assess any kind of changes in the lower leg, in the thigh, and in the total limb, we were able to place the electrodes in a different manner, and so we were able to investigate. Now let's go to the literature about compression and bioimpedance. This is an interesting article which was focusing on, let's say, a pig spleen. So it was made on the animal, and they were able to demonstrate that when you exert very high compression, which means 80% than the basal 0%, you can get worse outcomes in terms of resistance and reactance. So again, it's a matter of dose. Too high compression can give you worse outcomes in terms of resistance and reactance, which was not the case with the classical compression, let's say 30 or 40% of the basal value. These are some data from this study. With 80% compression, the intracellular resistance increased, but the interstitial resistance decreased. So you did not remove the fluid from the interstices, but you removed the fluids from the inner cell. So this is interesting because that means that when we compress too strong, we have somehow a removal of the fluids from the inner part of the cell, not from the interstices. This is another article from the group of Gianesini, where they demonstrated with bioimpedance, that's another kind of bioimpedance device. So they investigated, in fact, the extracellular water, and they showed that the improvement of the extracellular water with the graduated compression stockings happen only when walking with stockings and not in a static, let's say, position. This is another study where they investigated bioimpedance analysis parameters with ulna boot versus, let's say, conventional dressings. And using ulna boot, they were able to demonstrate that after 1 day time, the bioimpedance values improved, which was not the case with classical, let's say, conventional dressings. So now let's move to our own experience. Somehow we were able to demonstrate that when performing, let's say, catheter foam sclerotherapy plus phlebectomy for varicose veins, compression 3 millimeter or 35 millimeter of mercury stockings gave different results. This is a kind of summarizing slide. You can see here again the main parameters of bioimpedance. So to make it short, using higher compression, such as the 35 millimeters, Struva 35 millimeter, you had an improvement of reactance and limb LDEX, both at 7 days and at 40 days. But what was interesting was that all the parameters, let's say resistance, that is fluid, reactance, that is tissue, significantly improved at 7 days after the operation, and they decreased at 40 days in both groups. So that means that without stockings, you can somehow deteriorate the improvements that you get with Struva 23 or Struva 35. Then we investigated the complex decongestive treatment of lymphedema, which included, of course, in this case, bandaging, and manual lymphatic drainage and so on. We investigated with volumetry and with bioimpedance. After 6 days course of the complex decongestive treatment, we had the volumetry reduction both in the total limb and in the lower leg, which was statistically significant, as you can see here. So now we are talking about volumetry. Then we investigated the bioimpedance parameter, and the resistance increased after the treatment, which means that the fluid decreased, both in the total limb after 6 days and in the lower leg, as you can see from this slide. That was the case also for reactance, which improved because it increased after the 6 days of the congestion treatment, both in the total limb and in the lower leg. And that was the case, of course, also for LDEX. To go to the very interesting point, what we found, thanks to the help of Luca Bastiani, our statistician, we found a very good correlation between the variations of resistance, reactance, and the LDEX, and the variation of volumetry. So somehow we were able to demonstrate that when employing this technology, you can correlate the volumetry changes with the tissue and the fluid changes in the limb. Now we want to present a very little data about a couple of incoming studies. You probably remember this study that with Dr. Mosti and Professor Parch I had the luck to perform. We published 5 years ago this study about the adjustable Velcro compression devices in chronic edema, which was better than inelastic bandages in reducing the venous edema in the initial treatment phase, which means at 1 day time and 7 day time. What we did, thanks to the improvement of the technical softwares and the revisions of all the data we had about that study, we revised all the data that we had, and the very similar improvement were found when using CIRC versus multi-layer bandage at 24 hours and at 7 days. You can see here, for example, bandage is in red and in green is CIRC. So if we look at resistance, reactance, and cell membrane capacitance, again, CIRC was better, both at 24 hours and, as you can see here, at 7 days. So it is another demonstration how bioimpedance can very clearly, let's say, evaluate, assess the changes in fluid and in tissues. Going to the end, this is a very simple and very, let's say, a preliminary study that I want to present you. We investigated just 5 working subjects with occupational leg edema, and we wanted to see what happens with stockings, class 1 stockings, panty stockings, for 9 hours, from 9 in the morning till 6 in the afternoon. And we investigated just bioimpedance parameter. And very briefly, again, you can see that a little improvement if you investigate these patients the first day without stockings, the second day with class 1 stockings, you have an improvement of resistance in the total limb, an improvement on reactance, and an improvement of cell membrane capacitance. That was the case for the right and for the left leg. So using the stockings gives you improved values of bioimpedance. And again, that was true also for the total limb. What is somehow interesting, I go to the very end, is that also resistance of the total body improved a little bit when you have stockings on your limb. What does it mean? It just means that you increase your diuresis because the fluids somehow exit more thanks to the stocking. Probably this is our explanation. So this is my very last slide. The bioimpedance spectroscopy is a safe and reliable technology in limb edema assessment, and our data show a very good correlation between volumetry and bioimpedance parameters. And as we are starting to show, monitoring of compression therapy by bioimpedance spectroscopy can be of very important scientific interest because we can quantify the changes of fluid and tissues thanks to this, let's say, technology. Thank you very much. Giovanni Erhardt, are you there?
Attilio.
Yeah, okay.
Thank you, Attilio, for your brilliant presentation. We will certainly have questions afterwards, and now it is my pleasure to introduce you Nic Morrison, who actually doesn't need any presentation. Everybody knows him very well, and is presenting today perspectives of compression treatment in Phlebolymphology. Nic, please, the screen is yours.
Thank you very much, Giovanni. You can hear me?
Very well, and we can see your slides.
Okay, perfect. Thank you. So I will. I have the pleasure of wrapping up here because much of the this presentation has been already touched on by other speakers, and so this will be kind of a summary, at least partially a summary. I've noted some technical difficulties throughout this program, and I am quite sure that all 13-year-old children throughout the world are laughing hysterically at our inability to control the technology with which they are very familiar. So I will go ahead and talk about compression therapy, the risks and the contraindications. That is my disclosure slide. That's a beautiful place up in northern Arizona, my home state, called Antelope Canyon. So this is the presentation down below, the publication. I'm going to summarize. So this was published in Phlebolymphology in 2020, just a couple of months ago. So we all know that there are a variety of compression technologies that we can use, from thromboembolic stockings to medical compression, compression bandages, adjustable compression wraps, and intermittent pneumatic compression. This is the consensus group that developed this publication. And we did a systematic literature search of articles and guidelines from up to 2017. We then updated it to 2019, but there weren't any new articles. So these are on the left, the search terms that we used to search articles, and they were cross-referenced with the terms complication, adverse events, contraindications, side effects, and risks. That is the algorithm that we followed. So the initial search revealed about 3,400 articles, and down in the bottom you can see that we reduced this to 62 articles that have evidence base for us to do a critical analysis. Now, this is some of this. These are the side effects and complications that are generally attributed sometimes to compression therapy. And I think it's instructive to look at the bottom to identify and quantitate what is meant by very common, common, uncommon, rare, very rare, and a frequency not known. When I first saw this, it was presented by J.J. Gex to me, and I was surprised that my definitions of very common and common were not according to this calculation. So you can see that skin irritation and discomfort and pain are a common side effect. A rare side effect is distal edema, and then all the others are very rare. So allergic reaction, bacterial fungal infections, soft tissue damage or necrosis, nerve damage, arterial impairment, venous thromboembolism, and cardiac decompensation. We'll speak to all of these as I go along. So the first recommendation is that every patient that's going to receive compression is screened for conditions that might increase their risk of complications for any compression device for appropriate fit and application, and that the contraindications for compression treatment must be considered to limit the risk of side effects. So patients who have congestive heart failure, infections, ankle pressures less than 50 millimeters of mercury should all be carefully screened. Next, we should use adequate skin care prior to the application of compression to be sure that the patient will not develop complications. So wound care and topicals are important. And then we want to prevent allergic skin reactions. So we should avoid allergenic substances such as dye in compression hose, natural rubber, and those sorts of things. And in patients with discomfort and or pain below compression garments, we recommend checking the correct indication to be sure that the pressure level, the material used, the fittings or bandage techniques are all done correctly. Typically in the ankle and foot are where some of the problems originate. Now in patients who are developing forefoot edema while wearing compression, we suggest that the forefoot and toe bandaging or compression pieces be applied so that they don't get further edema or don't worsen the edema that's there. And in patients with bacterial or fungal infections beneath the compression device, we should consider using topical antiseptics or topical antimicrobial medication. However, in those more severe patients with systemic symptoms of erysipelas or cellulitis, we recommend that systemic treatment should be given to these patients. If the compression application or material is suspected to contribute to the infection, we suggest a modification of the compression. However, we should note that there is no evidence that well-applied compression causes or aggravates infection. And I appreciate Dr. Erhardt Rabe's comments along those lines. Now, as we know, according to the law of Laplace, the local pressure below compression may be higher than expected, particularly over bony and tendinous prominences, such as at the ankle, the tibia or the fibular head, or the Achilles tendon. So the recommendation is to check those locations for skin lesions due to pressure. And to prevent tissue damage or necrosis and nerve damage, because of those localized areas, we should protect them, regions overlying the tendons, nerves, and bones. By decreasing the local pressure, you can insert soft padding to diffuse the pressure. You can use a lower overall pressure. You can make sure that the compression devices are fitted properly. So, with specific precautions, padding and care of the fit and low pressures, we can be especially careful with those patients with polyneuropathy, or in the elderly, patients with atrophic skin, or even sometimes those anorectic patients. And then we suggest considering that pressure-induced nerve damage, particularly, for example, around the fibular head, excessive local damage pressure, local compression pressure may be due to ill-fitting compression hose, thromboembolic stockings, or compression bandages. And to prevent these local pressure regions of nerve compression, the correct sizing and application of the compression is warranted. The higher risk for nerve damage in patients with diabetes and neuropathy, special caution should be applied. And again, I applaud the previous presentations. Now, we recommend checking the arterial circulation before any kind of compression therapy. So if the foot pulse or ankle pulse is weak or not palpable, an ABI absolutely should be measured and calculated prior to initiation of the compression therapy. And the circulation status before any compression is initiated, again, if the foot pulse is or ankle pulse is weak or palpable, an ABI should be measured. Now, in severe PAD, systolic ankle pressure of less than 60 millimeters, a toe pressure less than 30 millimeters is a contraindication to medical compression hose. However, this contraindication does not apply to intermittent pneumatic compression in patients with non-critical leg ischemia, and inelastic material can be applied with a low resting pressure. So in every patient with impaired perfusion, the clinical effect on the medical compression on the leg blood supply should be carefully monitored, as has been indicated in the previous presentations. Here's an interesting situation. So in patients with lower extremity bypass surgery, there is no direct effect of compression on the bypass itself, assuming it is not epifascial. If it is epifascial, you should be very careful about application of compression overlying that bypass conduit. And for all patients with chronic leg ischemia, recommendations regarding the use of medical compression should be followed. Now, with respect to that tourniquet effect that is frequently seen, it can cause local superficial venous thrombosis or thrombophlebitis, especially in combination with prolonged sitting, such as a long haul flight. We should make every attempt to avoid that tourniquet effect by inappropriate application of compression hose, thromboembolic hose, or bandages. And with respect to those patients with congestive heart failure, In those patients who have a stage 4 congestive heart failure, this is an absolute contraindication to compression. In the patient who has stage 3, so less severe, we can use compression as long as that patient is absolutely requires the compression and they are clinically and hemodynamically monitored. So this essentially means an inpatient monitoring. In as less severe cases, the compression only leads to very short phases of increased cardiac load and may lead to a substantial reduction of peripheral edema, as we have seen in the previous presentations. We should consider compression is not contraindicated in acute thrombotic episodes, and Dr. Thomas Urbanek spoke to this very well. So in the hands of experts, proper compression leads to an immediate improvement of pain and edema. And speaking of experts, that's a very nice image taken from a trip to South America with Drs. Ugo Parch and Giovanni Mosti applying compression. Special precautions should be given for those patients with borderline indications and should be discussed on a case-by-case basis. So if there is a favorable assessment, then low pressure compression, the use of modified compression, including compression materials, and the use of padding can be used to reduce pressure peaks. Now, we recommend considering the following contraindications. These are absolute contraindications for thromboembolic, adjustable compression wraps, medical compression stockings, and elastic compression bandages. In those patients, and here's some solid numbers, in those patients who have an ABI of less than 0.6, ankle pressure less than 60 millimeters mercury, toe pressure less than 30 millimeters mercury, and transcutaneous oxygen pressure less than 20 millimeters mercury should not have compression. If there's a suspect compression of an existing epifascial arterial bypass in the lower extremity, another contraindication. Severe stage 4 of congestive heart failure is a contraindication, and the routine application in patients with stage 3 congestive heart failure, unless they can be clinically and hemodynamically monitored. If there's a confirmed allergy to compression material, and in those severe diabetic neuropathy patients with sensory loss, may not apply to inelastic compression exerting low levels of sustained compression. Again, a beautiful presentation previously. So in conclusion, there are limiting side effects of compression therapy are common. However, adverse events are uncommon to rare. And with careful attention to compression modality, materials, application, and vigilance for serious complications, that'll avoid the majority of dangerous complications. Thank you very much for your attention.
Thank you. Thank you, Nic, for this very comprehensive presentation. And together with Erhardt, we need to chair the discussion now. And the recommendation from the director of CIRC is to limit this discussion to 15 minutes.
Okay.
As from the program.
So Giovanni, the first questions to your presentation, I think.
Yeah. Tell me.
From the audience, there are no questions for your presentation, Giovanni.
To the question.
No, there just a remark. There are no questions from the audience to your presentation. So everything seems to be quite clear and perfect.
I have a small question, Giovanni. We know, of course, you didn't speak about diabetic ulcers, but venous ulcers in diabetic patients.
Yes.
However, we know that also ulcer healing, diabetes, as you showed, diabetes mellitus is a let's say, slowing down factor. You have more infections in those patients. You have a slower wound healing. Is there any evidence that with compression treatment you could speed up the healing of the ulcers, or doesn't that matter in any way?
So, you know, Erhardt, regarding diabetic ulcer, we don't have any data. There are no data at all. So I cannot respond to this question. Theoretically, we should have some advantages, but we don't really know, because the only other study published regarding ulcer in diabetic patient is something like our study. It was published more than 20 years ago, but also in this case, he reported data on venous ulcers in diabetic patients. So actually, unfortunately, we don't have any data on diabetic ulcers, on the true diabetic ulcers. The aim of my study was to prove that in diabetic patient you can apply compression, because as you know, even in reviews on leg ulcers, diabetes is always an exclusion criteria, and this is not anymore, doesn't make any more sense, because it is well proven that you can apply compression in venous and mixed ulceration in diabetic patient, provided you are applying a proper compression.
Yes, I completely agree. I think the main problem with compression in diabetic patients might be the foot and not the leg.
Yeah, I totally agree.
Pressure peaks in the foot region if you don't pad and are not careful.
We should be able to convince diabetologists to perform some studies on compression in their ulcers, in their foot. But at the moment, this is not the case. And this is not possible.
I think that is also true for edema, because also according to the next speak of Annette Erhardt, which was more on edema patients with venous edema and diabetes. Of course, we have to differentiate between venous edema or edema of other origin in diabetic patients. And then we have also a diabetic edema because of hyperperfusion and hyperpermeability of the microcirculation. You may have no venous insufficiency, no venous edema, but you might have only edema due to the diabetic situation. And that is also a point to treat. You know, that's two different entities. You may be able to treat diabetic edema by compression, and of course you are able to treat venous edema in diabetic patients.
Yeah, but as far as I understood from the paper, I think they are just speaking about edema without differentiating between diabetic edema or venous edema or dependency edema. So just edema in diabetic patient, and this study is something new because it was performed by using the technology to study the microcirculation. But there is also another paper published by WHO in the United States, just reporting data on edema in diabetes. And just by using a stocking with a very low pressure, if I remember correctly, about 50 millimeter of mercury. And also in this case, edema was very effectively reduced by this low compression stocking. Yes. And this is certainly something important in diabetic patients.
Yes.
We got a question from the audience to Giovanni. Who should apply the bandage, doctor, nurse, or who else?
No, it is just important they are expert and they know what to do. And this is also the reason why I would be very happy if we could have data on stockings and on adjustable compression wraps in this kind of patient, because these devices are very much easier to handle.
Next question, contraindication when there is a low ABI. It's not suitable in diabetic media sclerosis. So how do you decide about compression?
Nic.
I'm not sure I understood the question.
The contraindication when you have a low ABI, is it not suitable in diabetic media sclerosis? So how to decide about compression?
Yeah, that's. I think that the measurement of the oxygen content is important in those patients, and that really helps you determine how much compression to apply, if to apply any, and how much.
Okay.
But anyway, in this case, when the ABPI is not sure because there are problems with media calcinosis, you need to measure the toe pressure. That is even more difficult.
Or the TCPO.
Or TCPO, yeah.
Right. I have to interrupt for a second, I have a question, a very basic question, because you in Europe are used to speaking in classes of compression, and I didn't understand for sure the difference. What is the compression of class 1 and class 2 in Germany?
The class 1 in Germany is 18 millimeters Hg to 23 millimeters Hg, as far as I know. And class 2 is 24 to
23 to 32.
23 to 32, yes.
Okay,
That's
great.
Europe.
It's different from United States.
Yes, that was my point. You folks are used to thinking in those terms, and we're much more used to thinking in millimeters of mercury.
Yeah.
And you know that since years and years, together with Ugo, we are recommended to go for compression pressure and not for classes, because classes are extremely amazing. In the United States, you have another classification. In France, there is another one. In England, there is another one. So just speaking about classes is a mess.
Thank you, Giovanni. I didn't want to say that as somebody from the U.S.
Oh, you know, I like US, and especially now that you have a new president.
We are joyous.
Question to Annette Erhardt. Thank you for your interesting presentation. What about the foot shape? And you have problems with deformity on secondary diabetic foot problems. Would it be a contraindication for the stockings?
Yes, thank you very much for the question. We included in the study diabetic patients, of course, without any diabetic foot syndrome and without any acral lesion. So we had the University Texas wound classification grade 0. But nevertheless, the stocking will be available not only as a ready-to-wear product, but also as a measure-to-mate product. So, of course, as you already mentioned, in patients with diabetes, the foot shape and the leg shape is absolutely important, and the optimal fit is also absolutely important. And therefore, we also offer a made-to-measure option for patients with maybe different foot options or foot shape.
I have another question. Thank you very much for this very nice study, very interesting results. How you said that you had some pressure in the foot region. Mm-hmm. How high was your pressure in the foot?
Yes, when you compare it with a normal medical compression stocking, you have a difference between the ankle, where you have the highest pressure, and the foot. That's about maybe 3 to 5 millimeter mercury, depending on the size of the stocking. And here the delta is higher, so there's more a delta between 8 to 10 millimeter mercury difference between the pressure at the ankle, where the highest pressure is apparent, and the foot. But nevertheless, there is a kind of pressure in order really to ensure this optimal pressure only also for the venous system.
So it's more close to 10 to 15.
Yes.
Class 1 stocking and a little bit higher in the class 2 stocking.
Yes. Thank
you very much.
Next question from the audience. What is a different technology effect of this stocking from others, in which way?
Yes, I'm not sure whether this question arrived in the chat during my presentation, because at the end I presented the product features. Of course, it's a compression stocking with a graduated pressure profile. So of course we want to treat further the chronic venous disorder, but of course we want also to keep in mind the risks, namely the PAD and the PNP. And therefore, we have this specific product features I presented, namely the broad trigo border, then the ribbed structure, then, of course, the merino plush padding within the foot area, and also the 2 foot lengths and the tip seam. So I think maybe this question was before the features, or is this question referring to another topic?
I have another question. The edema, we talked about edema effects of compression in diabetic patients. I didn't understand, did you have any data on edema reduction in your study, or did you only look for microcirculatory parameters and for safety?
Yes, since the main issues regarding these patients at risk are the safety issues, of course, we really want to bring clarity into this safety issue and want really to demonstrate that the microcirculation is stable. We did not analyze the edema reduction because we know, hopefully, that medical compression therapy is effective regarding edema reduction. What we could demonstrate was regarding the relative blood flow on the microcirculatory area that I presented you on one slide, this summary in the table, that we have also, of course, an improvement of the microcirculatory blood flow. And therefore, of course, we can hypothesize that really also the arterial venous pressure gradient will increase and also the arterial inflow. But we did not direct parameter measurement of edema reduction, because I think then also this 6-hour time frame is maybe too short in order to demonstrate the chronic venous disorder edema reduction in this time frame.
But the indication for the stocking is edema reduction.
Yes, the indication is a normal chronic venous disorder from C0 to C5. So since we excluded all chronic wounds in the study, and there are also specific products for example, C6 patients, but the indication is C0 to C5.
But C3 is, with C3 we are starting with edema. So C0 has no edema.
But as I already mentioned, the chronic venous disorder is the underlying disease. And there we know that compression therapy is possible and is safe and is effective. And now, of course, we were more interested in this comorbidities, PAD and diabetes mellitus. And therefore, we focused on the safety issue.
Okay, thank you.
It would also be very interesting to have data at the beginning of the compression, at the end of compression, when the edema is over, hopefully, because certainly we can expect that microcirculation is even more improved, but we don't have data, solid data on that. So it would be also interesting to do something like that.
Concerning
Thank you very much.
Concerning edema, Mrs. Wu from the United States showed that edema reduction is also possible in these patients with kind of stockings.
And with a very low pressure.
With a very low
50 millimeter of mercury, yeah. Okay, Erhardt, if we don't have any more questions, I think we can conclude. You could conclude, or Attilio could conclude.
Attilio, will you conclude or shall I conclude?
Okay, well, okay.
Attilio is the boss today.
No boss here. The real boss here is Ugo, who unfortunately cannot talk too much with us today, but is following and is guiding our future steps. So Uwe will close if he's here somewhere, but I will say just a couple of words and then I give you, Uwe, the final word. Let's say we are happy because we had the time to share a lot of information. What I see is that more research in compression, and this is thanks to especially Giovanni and Ugo, who obliged the scientific community to study more about compression, not just class, just better feeling or edema reduction. So I think that CIRC may have this role to spread the research. That's why we hope that in the next future you can help us with some videos again in the YouTube, but also you can share our newsletter, and the next Congress will be much larger and in presence for sure. Thanks everybody, and now the very last word to Uwe. Thanks again to everybody for your patience.
Hello, Giovanni and Attilio. We are happy about this first virtual CIRC meeting, and we thank you all for your participations, the great speakers as well as every single participant. Especially, as Attilio said, I thank Hugo, the godfather of CIRC, and his successor Attilio himself. And then there are people behind who did a great job, like Uschi Patsch Brocke, as well as Vanessa Schingale and his great father Franz Schingale. Therefore, thank you for this great support. And I can only say this is an extraordinary year. And we wish you and all your families a great Christmas time, and that you and your families stay safe and healthy now and also in the whole year 2021. I hope to see you soon personally and have a chance to discuss with you and have a glass of wine together. Have a pleasant evening. Thank you all. Thank you very much.
Ciao, ciao Uwe.
Ciao, ciao. Buona serata.
Ciao.
Bye-bye to everybody.